Good afternoon, students, and this is Miss Bennett. I will be teaching your RNSG 1430 for Nursing 1. This is Healthcare Concepts 1. Our first lecture here today will involve comfort and sleep, and this will be found in Module 3 and then parts of Module 7.C listed below. All right, let's get started. Okay, so what exactly is comfort? So comfort is a state of feeling at ease, pleasant, or satisfied, being physically or mentally free from pain and suffering. Some sources of discomfort do include the physical, emotional, psychospiritual, social, cultural, and environmental issues. These can include pathophysiological problems, grief, loneliness, depression, sources of forgiveness, alteration in body image, such as like our Instagram filters, pollution, extreme weather, room temperature, and lack of privacy. So when we're talking about comfort, I want you guys to go back to that Maslow's hierarchy of needs. I hope at some point in your journey to become a nurse, someone has introduced this pyramid to you. If not, this will become very useful as you start anticipating your patient's needs and kind of start developing those nursing interventions for your patients from here on. So how we start this pyramid is we start at the very bottom and we move towards the top. So at the very bottom of this pyramid, this can be found on page 168. This is figure 3.1 in your Pearson text. These are our basic needs, which we call our physiological needs. This includes like our air, food, drinks, water, shelter, ability to breathe, sleep. So those are our very, very basic needs. And in order to accomplish comfort for a patient, we need to first start in this bottom tier and then move up as we progress, establishing their needs. So if a patient has a need, let's talk about a homeless person. If they don't have a place to live, are we going to be able to address some of these other issues that they might be having, issues with self-esteem or feeling belonged or even safety or feeling secure? No. So we have to start here. We have to make sure that all their basic needs have been met, and then we can proceed to the next areas. So each level builds on one another. For example, once basic needs like the food and shelter are met, an individual feels safe, and then we can move into that safety and security section, and then once that is achieved, then they are more willing to establish a relationship with us or a relationship with providers as they start developing that connection with us. So another thing to look at are what we call our antecedents. So an antecedent, I hope Ms. Young has introduced you guys to that term. In order for comfort to exist, we must have antecedents that go along with comfort. So these do include a functioning circulatory and neurological system. And for that case, in order for a patient to be able to have feelings, as in pain sensory, things like that, or to be able to know if our circulatory system is working, there's going to be lots of sensations that we're going to feel. And in order for a patient to have those sensations and feelings, they obviously have to have a neurological system working as well as their circulatory system. Patients also have the ability to discern from comfort to discomfort. And then when we talk about a noxious stimuli, this is without harm. So noxious stimuli just means that that it just is a warning signal to our body. The best example I can give you is when you get a burn, and if you happen to touch the side of a pan or a cookie sheet, that sensation that you're first feeling is being able to recognize that something could happen, It doesn't necessarily always mean that severe harm happens, but it just gives you that signal that something could get worse if I don't remove my hand from that pan. So that's the best way I can describe that noxious stimuli to you guys. So the antecedent for comfort is the ability to discern from comfort to discomfort. So we have to be able to sense those interactions as well. Okay, so let's look into some comfort-seeking behaviors. First, we have our what we call our unhealthy behaviors. These often, unfortunately, are like a temporary fix for a lot of individuals, and for some of these individuals, as our bad habits develop, they can turn into something abusive, like substance use, excessive food intake, alcohol abuse, some just normal things that might be pretty mild at first: nail biting, hair pulling, gambling as well. Some healthier comfort seeking behaviors can include prayer, meditation, relaxation techniques, massages, social support, and counseling. But I want you guys to understand that if we are recognizing some unhealthy habits in our patients, that obviously they can lead to some detrimental effects and long-term can affect their health overall. I just put this on here just to also remind everybody, because we are trying to look at patients from infant to adult. It's also kind of important to tie in some of those relationships that can happen between children and adults as well. So I thought this was very interesting. It kind of pulls in those unhealthy coping mechanisms or comfort-seeking behaviors that some individuals can develop. So more than 10% of the U.S. children live with a parent with alcohol problems. I'm not just trying to trigger just alcoholics. I'm just trying to say that all adults can develop some poor choices in their lives, and it doesn't necessarily only affect them, but it can obviously affect those around them, their loved ones, and family members. So just kind of keep that in mind as we kind of dive into this a little bit more. Okay, so some consequences, obviously, of comfort-seeking behaviors, like I discussed a little the slide before. So those negative consequences, so those unhealthy behaviors, what they can potentially lead to is an unintentional overdose, increased heart rate, respiratory rate, obviously some hypertension or elevated blood pressure. Some suffering can happen. Obviously, if we are doing something to ourselves, like even severe, nail biting, where obviously can cause harm to ourselves. We can also create a loss of security or support. And then eventually, kind of like that picture, it may lead to physical or emotional damage within our family structure or family system. Some positive consequences, especially with those healthier seeking behaviors, is we're able to remain calm under stress. We're able to cope with certain situations. We have positive social interactions with individuals. We can easily adapt to stressors. It can often build our confidence. And then obviously having more of a healthier habits can obviously lead to ability to perform ADLs as well. So what is our nursing role in the whole comfort and sleep system here? So our role first is to recognize our cues, or this is when we kind of do our assessment. We need to kind of understand what level of comfort our patients are in, so that way we can further develop a plan or interventions to help them either achieve a greater sense of comfort or just improve their overall health. So the very first thing we need to do when we assess somebody, we're going to look for our signs or symptoms. Often in this Pearson book, it will be called manifestations. So don't confuse that. It is all the same terminology. It is similar terminology, so just make sure you understand it is meaning the same thing. So when we are looking for those signs and symptoms, this can be objective, which is something we observe, or subjective means that the patient either speaks it to us or describes something to us. This can be found in your page 174. this does include a comfort assessment table. It really dives deep into some different um, ways we can kind of assess those comfort levels and looking at those manifestations. I would highly recommend looking at that table and really, I'm not going to sit here and read it to you guys. I just want to make sure that you do look at it and then know exactly where that is if I happen to bring it up in class. Um, these are things that we'll describe like our normal findings, abnormal findings, and then some developmental considerations. Another thing when we are kind of gathering those signs and symptoms is we're also going to do a patient interview. This just some simple explanation of this can be often that pain scale that we'll talk about here shortly. Just knowing how bad their pain is. Is it a 1? Is it a 10? And then because we were also talking about sleep today, we also kind of want to know their sleep habits. Do they go to bed early? Do they go to bed at 1 in the morning? Do they work night shift? It's all those type of different things when we're kind of gathering that patient interview. And then we're going to also do our physical exam. This can include just more of that objective side of our assessment. So we're going to look for those facial expressions. Do they look like they're uncomfortable? Certain cultures and as well as certain patients may have trouble expressing that they are in pain or choose not to ever tell us that they are in pain. I always like to tell a story about a farmer. He's never going to probably use the word pain for us. They're a lot of times these individuals are pretty tough guys, or they could be a lady, but they don't really complain a whole lot. So we sometimes have to recognize that they might be in pain or distress before they can actually verbalize that that's what's going on. We might even notice body posture, vital signs, of course. I want you to really look in that book where it kind of talks about what vital signs can do when we are in pain. It doesn't always necessarily mean having normal vital signs does not mean that we're not in pain. It's just sometimes those can be signs that we can recognize, oh, something might be going on. Some diagnostic testing that we can do. Obviously, x-rays, CT scans, MRIs can obviously show if there's something wrong with a joint or muscles or bones in our system. We also can show some inflammation as well. Lab work that we can often use to kind of determine if there could be a problem with comfort does include our lab work that can show elevated white blood counts, that can show infection. Other vital signs I forgot to mention, temperature. Obviously, if somebody has an elevated temperature, they may also not be feeling comfortable or they may have pain somewhere. And then we'll dive a little bit deeper into some sleep studies. Those can also show some different sleep disorders that can be contributing to our level of comfort if we're not getting enough sleep at night. And then just remember that we can also assess obviously our environment, our physical environment that the patient is in or the room that they're in. You can also look into their psycho-spiritual, social, cultural, or just emotional surroundings as well. I want you guys to kind of think of the family dynamics too in that role. Do they have a support system? Are they miles and miles away from home and their support system lives 4 hours away? Especially here in the Panhandle, when you guys start working with patients in the hospital, you'll notice that we'll have patients from Oklahoma, New Mexico, even Kansas sometimes that travel here for care or are flown here because they were in some sort of accident or something. Or sometimes truck drivers driving through, things like that. On our interstate, we'll have to be here for an extended part of time to get some treatment that's necessary, and sometimes they don't have that support system with them. Okay, let's look into our analysis and planning phase. So this is where we're kind of like, after we've collected our assessment, this is when we're starting to kind of start thinking about what does our patient really need? Are they how can we help support that patient if we need to, if we can make a goal for them or they can make a goal for themselves, how can we support that patient in achieving some sort of goal for recovery of some kind or improving comfort? So when we analyze cues, we are often asking the patient what is going on with the patient, what is causing this disruption to comfort. As we start looking into more of the planning side, we start to try to think of like a hypothesis, like what could ultimately be going wrong. Could they be having a fever and having pain from the fever that's actually from strep throat? Or could they be having some back pain from an injury? So this part of the nursing process is we're really trying to kind of put all our data and knowledge together to kind of see where we anticipate this patient's need will be. And then we start to plan, or we do what we call a generate a solution on what goal or outcome we want this patient to achieve. So if we want them to be pain-free, or if we want their pain to be less than 5 on a pain scale, those are some great outcomes or goals for patients. And then we start trying to think of those interventions or nursing strategies that they may need. So if our goal for a patient is to not have pain greater than 5 on a pain scale, do we need to hopefully work with them to develop a schedule of when to take their pain meds? Or is there something else that could support them besides medication? Could a heating pad provide some comfort? Could, if their issue is sleep, do we need to enforce visitation hours for this patient, making sure that they are able to go to bed at 9 o'clock at night while they're with us? Just some different interventions that we can do as nurses to support our patients. And then obviously when we're supporting them, we're obviously helping them achieve their ultimate goal. Okay, so we're going to look into a couple exemplars. Each one of these modules that we will cover in our class, there will be roughly between 3 or 4 exemplars that we will dive deeper into a little bit of the pathophysiology, more deeper into the signs and symptoms, different treatment options, how we diagnose these areas. And that is what I'm hoping to bring into the classroom, is our deeper dive as well into the exemplars as we start presenting different patient scenarios to you guys, case studies, things like that we'll all do together. So hopefully to make all these connections. Okay, so our first exemplars here do involve pain and sleep. And with pain, we will be covering acute and chronic. And then with sleep, we will be covering insomnia and sleep apnea. Okay, so here is pain. So pain is both a physical and emotional experience. And when I say physical, I mean sensory. So remember those nerves when we're talking about pain. So it can be a result of an actual or potential to tissue damage. Pain is caused when a stimulus causes electrical impulses to travel from the peripheral to the spinal cord. When injury or tissue damage occurs, the body releases chemicals that excite or activate those nerve endings, causing the pain. So pain may start, obviously, it can start anywhere in our body, but it obviously starts at one point and then travels up our spinal cord to tell our brain that something's going on. So I will keep using that burns scenario, but it's the easiest thing to kind of think of. So if you're touching that cookie sheet with your hand, that sensation obviously is traveling up your fingers all the way up to your brain to tell your brain to pull your hand away. So that's the best example I can describe, kind of how that stimulus and electrical impulses, how they're traveling up our spinal cord there. Pain can be described in terms, subjective terms, can be described in location, intensity, quality, duration, what aggravates the pain, and then what can obviously help relieve that pain as well. So definitely look on pages 179 to 204. There is, this is basically where we're going to break down each one of these areas when we're talking about pain here. So if you're wondering, where the heck are you, Miss Bennett? I'm in what we call that exemplar 3.4. So that's this section of this module 3 that we're going to talk about. Some other tables and charts I want to make sure to mention to you guys I want you guys to look at are table 3.1 and table 3.2. This is on page 181 and 182. This is the types of stimuli, and then obviously the summary of types of pain. So when we're talking about the types of stimuli, um, it basically is just kind of breaking down, obviously, how we were talking about the pain with a burn. That's obviously more thermal, right? From this chart, that type of stimuli. Then you can have something more biological. So, like, let's say it is strep throat causing the discomfort in our throat. That's more bacterial related. Some chemical reactions would be obviously if you were to interact with some kind of chemical substance, but it can also include like tobacco smoke, things like that. So we're just kind of hinting that we will talk a lot about senses here in the next few weeks too, when we kind of dive deep into some neuro things. But just kind of keep in mind that there are lots of different sensations throughout our body, and just because it may not be like a burn or a cut, it still doesn't mean that our body isn't experiencing pain or discomfort of some kind. And then if you do look on page 182, it does go over a summary of pain. There are several different descriptions and types of different pain. We're mostly going to focus on those acute and chronic pain types. But we are going to talk a little bit about some breakthrough pain as well as central and phantom pain as well in this chapter. Okay, so another thing I want to mention is that peripheral nervous system. So within our nervous system, that's kind of that center where all our brain signals, where our brain gets all those pain signals. So it is composed of sensory and motor neurons. Pain perceived through our sensory neurons, responded to through motor neurons. Connections occur within our spinal cord. Neuroreceptors specialize pain receptors. All these tissues within our body system, except for the brain, have what we call those neuroreceptors that basically are the pain receptors. There are actually more receptors, obviously, in our skin, in our muscles, than maybe our body organs, if that makes sense to you guys. So that's how we are able to feel, touch, things like that. When we are experiencing something like when we're touching that cookie sheet and it's hot, we do release those biochemicals that stimulate those neuroreceptors, and that's what signals our brain to obviously, hopefully, release the cookie sheet there. Okay, some objective observations. So these are things that we actually can see or observe from our patients. So this can also be some diagnostic things. So this can be some vital signs. They can often show an elevation in blood pressure, heart rate, and respiration rate. You may also observe the patient having muscle tension or rigidity. Sometimes the patient may look really pale. When pain becomes severe, there can also be the reverse effect with our vital signs, and then their blood pressure may actually bottom out, as well as their heart rate. Some patients, especially when I think of patients that have kidney stones, there can be a lot of nausea, vomiting, just because the pain is obviously really significant. Fainting can occur. Obviously, when we are touching a cookie sheet, if you witness somebody touch a cookie sheet, obviously we're going to withdraw with pain. You may obviously, especially if it's like an infant or maybe somebody that's not able to express the pain to us. You may see the facial grimacing. They may become very restless. And then there's obviously some guarding that you may observe if somebody's experiencing pain. Okay, we're going to dive a little bit deeper into the pain scale here. So how do we determine and how do we document or report a patient's pain level? This is usually documented by location, intensity, and quality. And these are all questions that we are required to ask a patient at least once a shift, if not multiple times a shift, as we're checking on a patient. Depending on if they need pain medication, we are obviously having to go back and reassess their pain levels to see if the pain medications have worked. So as you can see here, this is that figure 3.4. This is the Wong-Baker face rating scale. This can be obviously very helpful for some pediatric patients, or even maybe some patients that don't speak English or may have trouble, maybe they're intubated and they're not able to express that they can exactly reach a certain number on their pain scale. So sometimes we can give a patient this chart and they can just point obviously to the smiley face or the sad face, depending on where their pain level is. It's just like our pain scale that we verbally ask a lot of patients, especially adults. How is your pain from a 0 to 10? Obviously 0 means you're not in pain and 10 means you are. Just definitely start building the habit of asking detailed questions when you ask somebody, are they in pain? So I try not to just say, are you in pain, and just leave it like that. Sometimes I want to pry just a little bit. If they say they're in pain, I want to know where. Where is it? Does it come and go? Could you describe it for me? Anything I can collect from that patient, I can document and potentially could help a doctor, assist a doctor with diagnosing a certain problem, or help the doctor know what maybe some treatment options could be for that pain. And like I said before, especially like some cultural aspects, some individuals just will not like the word pain and they won't want to use the word pain. So you may say, are you in pain? And they're going to tell you no, but in reality, they really are hurting. So you have to think of a different way to sometimes ask them that question and still kind of get a feel for what's bothering them or where they could be hurting. So sometimes you have to use the word, are you in discomfort? Are you uncomfortable? Maybe you have to point out that, hey, your vital signs are really elevated right now. To me, that says that you might be hurting. Maybe, like, let's say it's a kid with appendicitis that, a lot of times those physicians are going to focus on that right lower quadrant. Is that where you can feel the discomfort? So we just have to be very creative, especially with our different age groups, populations, and cultural aspects of patients, really making sure that we are creative in how we approach our questioning, as well as just ultimately we're trying to get the best description that we can, so that way a doctor can use it for diagnostic purposes. So when we do look at that location, we want a location can tell a lot about pain for us. For example, if the pain is in that lower right quadrant, like I was talking about, sometimes, for example, a patient may suspect appendicitis, or if a patient complains of lower back pain that radiates down their leg, we may think that they might have problems with bulging or herniated disc. And then sometimes when the patients are describing the pain, don't be afraid to also use the word radiating. Does the pain spread from one area and go anywhere else? Does it extend throughout the body? Is the pain only just centralized? Is it only just in one spot? Or is the pain referred? So the best example I can give you guys, just thinking off the top of my head right now, is sometimes with we talked about the other day in skills, women that are having heart attacks. Sometimes they're having referred pain. So they can sometimes have the pain in the back of their necks, in between their shoulders, where gentlemen having a heart attack will have the discomfort right in the center of their chest, where women are having it more towards their back and shoulders. Sometimes especially since we're talking about heart attacks, sometimes those patients can also have that discomfort down that left arm, things like that. Intensity is another thing that we like to ask our patients. We often want them to describe that pain as mild, moderate, severe, and that's that pain scale. And that's why in order to be able to document that we assess the patient, we have to put a number in the chart. When we first went in and did our morning assessment, was their pain at 0? Great. So that way, when we go back and check them about middle of the day, oh, now you have pain at a 4, and then you might give them some Tylenol. We want to document that the Tylenol worked to relieve that pain. So that's why we have to really make sure we are checking that intensity. So that figure 3.4, I forgot to mention to you guys, that is on page 180 if you just want to look at that little section there. I think that's pretty much it on intensity. We talked quite a bit about that already. So quality. We often want them to really describe. Is there a way that they can describe or put into words what this pain feels like? Is it sharp? Is it tingling? Is it burning, throbbing, aching, cramping? Or like with the MI for a gentleman, does it feel like an elephant is sitting on your chest? Those type of descriptive words. Okay, we're going to break down acute and chronic pain. Make sure you guys do understand the difference here. So when we're talking about pain and we're talking about, so we've already talked about our location, intensity, quality. This is the duration, like how long is this pain been bothering somebody? So acute pain basically just means that sudden onset of pain. This can last from a few minutes, hours to weeks. Obviously, this type of pain, usually those individuals are able to recuperate less than 6 months. So it's a temporary pain. This can be, some examples of this can be like post-surgery. It's expected to have some discomfort and some pain, but obviously in the best case scenario, those patients do report that pain goes away over several days or even weeks, so that way they are without discomfort after their procedure. Acute pain it does signal to us that we have a tissue injury. It is often obviously that short duration, and it is often a autonomic response. So just like with that cookie sheet that we touched with our hand, it's that type of pain that we're getting, that quick signal that we burnt our finger, is very short-lived. In the long scheme of it, it's not going to last for years. Now, if I kept my hand on that cookie sheet and had a 3rd-degree burn and, something really severe, then yes, of course, that can develop into chronic pain. There are 3 categories of pain, and I want to refer back to that chart that kind of really dive deep into those different categories. That is table 3.2, that summary of types of pain. If you're wanting just a little bit deeper dive than what I'll present here, but just go back to that chart and just really make sure you're also reading the paragraphs surrounding these areas. But the 3 categories do include somatic, visceral, and referred pain. So somatic pain, I often try to think of somatic pain like it's within like a muscle. So it can also signal some inflammation. That's more of like a somatic pain. Visceral pain is often like an organ. So visceral pain, I always think of like appendicitis, or you could even think even of a heart attack, right? Because the pain we're actually feeling in our chest is that damage to that heart that we're feeling. And then referred pain, obviously that can be pain that you might be, like even gallbladder pain. You can have pain in that upper right quadrant from your gallbladder, but it can also that pain can also shoot to your back. And so maybe that's the pain that the patient's presenting with, is back pain, but in all reality, that referred pain is actually coming from their gallbladder. Looking into the differences with chronic pain, this chronic pain is often a result of ongoing is ongoing pain that originally maybe started acute, but it's going past the normal expectations of healing. So let's say you fractured a leg and you had pain obviously from that fracture in the acute phase. Well, it becomes chronic when after that 6-month period you're still having discomfort and pain in those areas. This can often last for months to years. It can range from mild to severe, and it can be caused by something that we are unsure why we're having this discomfort. And so when there's an unknown cause of why somebody is in pain, it's called idiopathic pain. This is also obviously an autonomic response, but that autonomic response, as we have to live with that pain day after day, our autonomic response does decrease over time, and that's kind of where you start building up that tolerance of pain. So if you're having that leg pain every single day for years from that original fracture, um, your your autonomic response, your body will try to protect itself by limiting that autonomic response, signaling to you that you're in discomfort and distress. But it doesn't mean that that pain goes away. I just want to make sure you guys understand that. It's a protective thing for your body to try to adapt to having that stimuli always shooting off every single day, but it does not mean you're without pain, obviously. Some 3 categories of pain can be obviously chronic recurrent, chronic intractable, benign, and chronic progressive. So those are listed again in that table 3.2. Pretty good descriptors there, as well as on page 182 in the paragraphs surrounding those. So recurrent pain, obviously, that is something that that can come and go, and but often is something that they're going to have to deal with for the rest of their lives. So the best example I can give for recurrent pain is like a migraine. Do you have a migraine every day? Maybe not necessarily. Patients don't necessarily have migraines every day, but it is something that they potentially will have to deal with for the rest of their lives. Chronic intractable pain can be things like back injuries, even some chronic things like fibromyalgia or arthritis even. And then, oh, I'm so sorry. Yep. The arthritis is more of that progressive pain. So I always think of like those little or elderly patients that have that arthritis in their hands. At first, they may just have some mild discomfort when they're working with things and using their hands and their joints in their hands. But then over time, that discomfort and that inflammation continues with that arthritis in their hands. That can obviously cause the pain to get worse several years down the road. Okay, we're going to break into acute pain here. So I want to make sure that you just understand that there are basically 2 main types of acute pain. Nociceptive pain. This arises from damage or inflammation from tissues where noxious stimuli, that means without harm, triggers that pain receptor. So the best way I can describe it again is somebody about to touch a cookie sheet with their hands straight out of the oven. So our body's obviously sensing that heat, and that's why our body tells us to pull our hands away. It's that noxious stimuli that's telling us something obviously can be worse if we leave our hand touching that cookie sheet. This type of pain can also be magnified with neuropathic pain, but does respond well to opioids. Neuropathic pain, on the other hand, is caused by nerve malfunction or injury resulting from trauma, disease, chemicals, infection, or tumors. This does usually respond well to antidepressants, antispasmodics, skeletal muscle relaxants, or topical anesthetics. So some examples, you can look at table 3.2, page 182. It's that table I keep pointing out here, going over all those different types of pain. But nociceptive, basically, that is our somatic, visceral, and referred pain. And then the best example I can give you guys is somebody burning either their hand or even like a sunburn. It helps that sunburn, that initial sunburn, just that mild sunburn, is just kind of that warning that our body signals to us that obviously if we don't get out of the sun, that more damage could occur or cause more injury. And then neuropathic pain is more from like a damage to our nerve system. So this often can be, it can be surgically related. So the best way to describe it to you guys is like, for example, when I had a C-section, there is some numbing because they do have to cut into the abdomen. There are some damage to those nerves, and there are parts of my abdomen that I just still to this day don't have quite the sensations that I used to have. So that would be more that neuropathic, because there is some damage to some of those nerves. Sometimes I still will have these little tingly or pins or needles type feeling around my incision. Is it something, for me at least, that's causing me distress? Not a whole lot, but it's just something that I'm aware of. Another great example is our diabetics that have diabetic neuropathy. They're getting that pins and needles in the bottom of their feet, where their sensations are not, because of the nerve damage that their elevated blood sugars have caused, they're not quite able to feel discomfort, or the discomfort is very, it can feel like that pins and needles in their extremities. This can be often intense shooting or burning sensations, and then this can include what we call that phantom limb pain as well. So kind of that surgical procedure. So like if we've cut obviously a limb off, some of these patients, their bodies in their brain will still signal that, let's say it was a foot that had to be amputated. They can still feel discomfort in their foot often, even though that foot does no longer exist, but those sensories in our brain are still telling our brain that foot is hurting. So that is that phantom limb pain. Okay, looking at chronic pain. Okay, so chronic obviously can be recurrent, like I was explaining. So that's where that pain comes and goes. Our best example, easiest example I can think of is just migraine headaches. And then chronic intractable benign pain is always present. And that intensity may vary. And I always try to think of like that person with back pain. They may, especially if they've had like significant damage to like a disc or something, a herniated disc, they may always have a level of back pain. It just may kind of come and go in intensity. And then those patients may tolerate it on most days. And then other days, maybe they have to take some pain medications to kind of help support their day. And then there's obviously chronic progressive pain, that this pain is obviously related to some sort of condition that worsens over time. Some examples of this is obviously maybe with cancer, as the cancer spreads within our body or a tumor grows, as well as like with arthritis, as that inflammation throughout our body or our joints gets worse, obviously that progression of the discomfort will continue. Okay, some other terminology. I know we've talked quite a bit about some that pain chart, but definitely keep referring back to that if you need to. There is obviously some breakthrough pain. I want you guys to be familiar with that term. Basically, that is the pain that arises between when a patient has regularly scheduled pain medication. It's that pain right before their pain medication is due. And as nurses, as we're taking care of these patients, that's definitely something that's important to report to the physician, especially if it keeps happening. Like if their pain medication is due at 2 o'clock, but by 12:30, they're having that pain come back a lot faster, we may need to talk to the doctor about some maybe an alternative pain medication or some alternative therapies or something to help extend that pain relief, to give those patients relief of their pain closer to that 2 o'clock mark. Sometimes it can include some over-the-counter medications, lidocaine patches, fentanyl patches. Those are just some quick examples thinking off the top of my head. Central pain means that there is some damage to the nerves in their central nervous system. This can often be due to a stroke, multiple sclerosis, Parkinson's disease, or trauma. So this is that nerve pain or discomfort that can occur. When I think of like central pain, I don't necessarily think of like pain. I think of more like tingling or that pins and needles type of discomfort that some patients may have. Now, some may actually have like true cramping or sharp pain, but it's more when I'm thinking of the nervous system, I'm thinking more just like the burning sensations or tingling type of discomfort. Pain threshold. Now, this is the point where an individual feels pain. So everyone's pain threshold and pain tolerance, that next word, is different. One individual might say that when they stubbed their toe, their pain was at a 2, but somebody else might say that was a 10 on the pain scale. So just kind of keep that in mind, what some individuals are willing to tolerate, and then what some individuals, like an infant, they're going to, scream or holler if we give them a shot. But like an adult, we just usually can sit there, take our flu shot, and be fine. Where if it's an infant or a child, obviously they're going to react differently than us when we're giving like a flu shot. One or the other isn't better. It's just that we just need to know that that's what that patient has. This is their threshold. This is their tolerance. And we need to try to develop interventions or nursing strategies to support that person in achieving either a reduction in their pain or bringing them back into that comfort. So talking about that, I want to make sure that, I forgot to go over one more thing with you guys. Sorry about that. So going back to this other terminology slide, I want to mention just a little bit more on that breakthrough pain. There are some different types of breakthrough pain. They do include incident, that is associated with an activity or movement. Idiopathic, that's that word that we talked about before, that just basically means we don't know why they may be having some breakthrough pain. And then end of dose medication. That's kind of that main one when I think of breakthrough pain, is their medication is wearing off before their next dose is due. And then when we talked about central pain there, central pain, because it is often that central nervous system focus, that pain can occur either immediately or it can be like a delayed response that some patients have. This pain can be constant. I even also think of central pain, even like with, if anybody's ever known a patient with shingles, that pain is what I would describe it is like a very intense nerve pain that those patients feel. A lot of times it's one side of the body that it seems to affect the most, and that pain can at times be constant. And it is like that burning pins and needles, kind of an aching discomfort. And sometimes depending on how severe the damage to that central nervous system is, like let's say it was a stroke, sometimes obviously the patient may not be able to feel. So you have to try to keep a lot of those disease processes in mind. So I know several of you guys, and when we were doing our demonstrations with the Foley, you're having the patient feel for the water temperature. So if they've had any kind of central nervous damage, central nervous system damage, they may not quite have those sensations. So we might have to get creative in being able to like have the patient feel the bath water, things like that. Or with our diabetics, why do we want them to constantly be checking their feet and making sure that they are wearing shoes outdoors, things like that? It's because they are because of their neuropathy, oftentimes they don't have the sensations that we want them to have in their foot, so that they can even tell that they've maybe injured their foot or their toe, something like that. Okay, back into interventions here. Sorry about that. So our interventions, I am not going to do a really deep dive into the pharmacology part of it, because you guys do cover these medications in pharm. So I'm going to just kind of highlight those. I'm going to really mention that you focus largely on these medication tables. They do start on page 187 and go through page 192. The tables are 3.1 and 3.2. Obviously, it goes down to the different categories of pain medications. We've got our opioids, our narcotic analgesics, non-opioid, co-analgesics, and then just our other medications that include anesthetics like lidocaine, medical marijuana, muscle relaxers, and tranquilizers. So really make sure that you do look at those medications. I'll talk here briefly about a few of them, but I also want to jump back to our non-pharmacological interventions that we can do. And these are just things that sometimes we don't even need a physician's order for. So what about positioning a patient? So if they're having low back pain, can we put a pillow under their knees or position the bed differently to kind of relieve that pressure or strain on their lower back? Can we offer any kind of massage, stimulation, heat or ice packs? Some patients may even be able to look into acupuncture, hypnosis, electrical stimulation units. I will show some pictures of one, kind of like those TENS units, that can help with discomfort. It is like a little nerve impulse, and sometimes it just helps especially if it's a muscle related thing, it can help often relieve that tension in muscle, get that muscle to relax to hopefully help decrease the pain sensation. Desensitization and then imagery obviously can help refocus the patient away from the pain. Looking into the pharmacological interventions, as I said before, so opioids or narcotics are considered that first line treatment for management of moderate to severe in pain, and include all controlled substances, and these do include morphine, codeine, oxycodone, hydromorphine, methadone, and Demerol. Non-opioid medications do include a lot of our, some of these do include some, well, actually all these are over the counter now, are what we call NSAIDs, or non-steroidal anti-inflammatory drugs. These are often available over the counter. These include our Tylenol, aspirin, Aleve, ibuprofen, and then now Voltaren gel. If you guys have ever looked at where like the joint pain area is over at Walgreens, I remember when Voltaren gel was, you could only purchase it as a prescription. So it's really awesome that patients can just get that over the counter now. Works really great for joint discomfort. And then we've got our co-analgesics. These do include our antidepressants, anticonvulsants, corticosteroids, bisphosphonates, used to enhance the effect of opioids by reducing pain or anxiety. Some examples of these do include our gabapentin, diazepam, hydroxyzine, and then amitriptyline. And then I want to talk just a little briefly. We don't have an example to show you, unfortunately, in the NRC, but when we do get to see this in our clinical settings, maybe not this semester, but as you progress through your levels, hopefully you guys will be introduced to a PCA pump. That basically is a pain medication that is given IV, and the patient does have control of when they want that pain medication to be delivered. It does have parameters and settings so that the patient, after they, let's say, it's morphine and they give themselves a dose of it. Well, if they keep pushing that button, it's not going to go off again until the doctor usually sets parameters to say when their next dose will be released. it's nice in the fact that the patient does feel some control of when they can get their pain medication, but it does have that lockout mechanism that will prohibit patients from overdosing themselves. Um, Usually those are very temporary when they utilize those in the hospital. Trying to think if there's even some other, it's not really a pump, but they have it's surgically implanted temporarily. It's like a, basically it's for some surgeries, some big surgeries. I think of cabbage patients. I think of like total joint patients that had like a total hip done. We can the anesthesia providers can block certain nerves, or they even have these like what I call like a little morphine pump that they can um, just attach at that surgical site temporarily, and then we obviously can remove that little pump temporarily. But it will. What's nice about those is they just will help that acute sort of pain just following surgery, and then those are usually relieved enough that we can discontinue those as the patients kind of recover and go to like oral medications. Um, with those medication tables, what I want to make sure that you guys do, especially as you're learning your medications with Miss Watts, is that you understand the common side effects of those medication types. I want you to understand their onset and be able to tell me that their duration of when do we expect those pain medications to work, and when do we expect them to wear off. Precautions, especially with relating to like driving or sedation, and then some other pertinent patient educations. For example, like NSAIDs or ibuprofen, we want to make sure maybe they eat with those so we don't have um, irritation on our stomach lining. Um, with Tylenol products, we don't want more than 4 grams of acetaminophen per 24 hours. So we have to often tell those patients if they're taking Tylenol on a regular basis to make sure any over-the-counter medication, read your labels. Make sure you're not also getting Tylenol from your cold and flu medication, and then you're taking extra strength Tylenol every night to sleep. So just make sure that they understand they can only have their body can only tolerate so much Tylenol before we are concerned about some liver damage. Those are just some examples, but just really look through those tables, really pull in what you guys are learning in pharmacology, so that way when you are bringing it to clinicals and bringing it to class, you're able to start making those connections. Okay, I do want to mention the something that's called a 3-step analgesic ladder. This was originally developed by the World Health Organization. This can be found on page 187. This is figure 3.7. Basically, the World Health Organization developed recommendations to help providers when they're prescribing pain medications. Obviously, if it's a pretty mild headache, do we want to jump all the way up to tier 3, giving them really strong opioids for severe pain? Or can we start at like tier 1 down here and maybe think of like Tylenol or non-opioid medications that could maybe support that patient at that level? And then if it doesn't provide relief, then we're going to go up to each level until their discomfort is under control. Often healthcare providers use what we call pharmaceutical approach. This does include a combination of multiple medications with different mechanisms of action in order to obtain the best outcome. So I know this has nothing to do with pain, but this is also kind of that approach that physicians use when we are addressing high blood pressure. Is it usually just one pill that often can help an individual's blood pressure problem? Not necessarily. Sometimes it takes a combination of medications to really achieve that outcome. And that's that same idea with pain medications. Sometimes it is a combination of an over-the-counter medication like Tylenol, and then maybe taking something a little bit stronger like Tramadol to really bring that complete relief for the patient, or at least to bring their level down to a more tolerable level for them. Definitely, nurses should remember to include alternative treatments and therapies to use in combination with pain medication. So, just because they're getting that oxycodone every 46 hours, do we have to give them oxycodone every 46 hours? Or maybe could we suggest maybe trying this time, or could we try using a heating pad for a few hours before your next oxycodone is due? So really trying to anticipate our patient's needs, as well as maybe finding alternatives without always necessarily jumping to that next tier if we can achieve it with something more mild. So underneath that slide on my note pages, I do kind of give some other examples of when we call that uh, pharmaceutical approach. So I've got Tylenol and Advil. Sometimes physicians will tell a patient to take them at the same time. Tylenol and Tramadol, like I mentioned. Some do ibuprofen 800 and Tramadol, or something like Tylenol and like a muscle relaxer. An example is methocarbamol or Robaxin. That's a real common muscle relaxer that's pretty mild. And then obviously with that Tylenol effect, you're getting the pain relief as well as like that muscle relief as well to hopefully help with some discomfort. Another thing I want you guys to make sure you look over and read in your book is this table 3.6. It is on page 197. This does kind of describe that influence of age on our pain perception and behavior. So really kind of look over each of these areas and maybe what to expect, and maybe some different techniques, especially because these are examples of some medication side of interventions. So, for example, I'm just glancing up here at the infant that obviously is crying unconsolably. Maybe we offer them a pacifier, or we swaddle them, or like let's look at this school age child. So they're trying. Let's say I always think of my kids when they do this. So my kids will react differently in front of mom, obviously falling and skinning their knee, versus like if they're with their friends at their house. I'll sometimes hear my youngest kid will have fallen and skinned her knee at their house, but she was brave, right, and didn't shed a tear. But if she was with me, she would have been crying uncontrollably, right? So just try to keep those in mind, that everything is not completely black and white regarding this chart. Just definitely want you guys to be very flexible in your approach to patients, from all the way from infant to adulthood, but also just keep in mind some different strategies that we can provide our patients that could help support their discomfort or pain, without necessarily having to jump straight into medication. Okay, so if you need a break, you can pause your VidGrid right now. This is a pretty lengthy lecture here, but we are going to move into our sleep disorders. And this is found in the Module 3 chapter, pages 225 through 234. And then part of this first part of when I'm talking about the pathology of sleep, that is actually found in Module 7.C, and that's pages 481 through 486. Okay, sleep disorders. Okay, so sleep is essential for health and healing. Without quality sleep, the body is not adequately able to rejuvenate. Inadequate sleep will affect almost every system in our body, potentially leading to chronic health problems such as depression, heart disease, hypertension, and diabetes. So diving deep into the understanding of sleep, this is in that Module 7.C area there. We have to look at what we call our circadian rhythm. And so our circadian rhythm is that internal process that controls the sleep and wake cycle. It occurs approximately every 24 hours. It does regulate the patient's internal biological clock and causes them to be sleepy at night and wake on their own in the morning. This does synchronize with environmental cues such as lighting and temperature. However, the body will maintain circadian rhythm without prompts. Factors that do affect that circadian rhythm and affect our sleep can be found on page 485. It is table 7.8. This does include daytime exercise, regular sleep schedules, bedtime hygiene habits, etc. So when we think of that circadian rhythm, this I even think of like a newborn infant. Sometimes they can get their nights and days flipped around, just depending on that environment. So sometimes when that would happen, when I used to work in pediatrics and would get those phone calls from moms, is we would express to them playing with them during the day, keeping the room really bright, maybe taking them outdoors during the day so they can maybe reset that clock, that internal clock, to show them this is daytime, this is when we should be more awake, and then darken the room, maybe black out curtains when we're wanting them to take their naps or sleeping at night. Those are just some suggestions there to help you kind of understand that sleep cycle. So within circadian rhythm, there is also what we call that sleep-wake homeostasis. This keeps track of a person's need to sleep. A pressure to sleep builds with every hour that a person is awake, reaching a peak in the evening when most people fall asleep. The homeostatic sleep drive also regulates sleep intensity, causing a person to sleep longer and more deeply after a period of sleep deprivation. Aldosterone is linked to this drive for sleep. While awake, the level of aldosterone in our brain continues to rise, which increases levels, signaling a shift towards sleep. While sleeping, the body breaks down adenosine. Did I say aldosterone? I'm so sorry, y'all. Breaks down adenosine when it gets dark. The body also releases a hormone called melatonin, and melatonin signals that body that it's time to prepare for sleep and creates a feeling of drowsiness. The amount of melatonin in our bloodstream does peak in the evening as it wears on, and then our third hormone called cortisol is released into the early morning hours that naturally prepares our body to wake up. So just know that as we are going through that homeostasis cycle and our circadian rhythm starts building there, several hormones, that adenosine and then that melatonin, start rising in our system. That does contribute to our sleepiness. And then obviously to help wake us back up, cortisol levels will rise in our body. Okay, so this is that table I did mention on page 485. Really look at these factors that can affect sleep. I want to make sure you read through those, really spend some time diving into these different areas. Okay, I'm not going to sit here and read that chart to you guys because I know you guys can read. So we will move on. I have a quick little video for you guys that kind of dives a little bit deeper into that circadian rhythm. We'll just watch that real quick.
If you've ever traveled across time zones, you've probably felt the jet lag from having your mornings and nights completely rearranged. So you might be wondering, can you reset your circadian rhythm? Hey everyone, I'm Faith. So what is our circadian rhythm? Well, our bodies are governed by an internal clock. And just as the sun rises and sets, our circadian rhythms are regulating when we wake up and when we feel ready for bed. The term circadian rhythm actually comes from the Latin phrase circa diem, meaning about a day. And just about every living thing is regulated by this internal clock. The daily circadian cycle begins and ends with your eyes, specifically what's known as Zeitgebers, or time givers. These perceive light and send signals to our suprachiasmatic nucleus, or SCN for short. The SCN has the very important job of releasing the hormones that can either make us feel wide awake or feel groggy and tired. For example, if you've ever been in a meeting or classroom, it's the middle of the day, the presenter's speaking softly, the lights dim low, it would only be natural that you start to doze off. Those SCN cells sensed the lack of light and told your body it was time to cool down, slow the heart rate, and get ready for sleep. any number of things can knock us out of our normal circadian rhythm. Changing time zones or even the seasonal change of clocks are the big ones. But even small things like a night out with friends or a late meal right before bed can affect your rhythm. So, is it possible to intentionally reset our circadian rhythms? Yes, but there are a number of steps you need to take. 1. Keep a regular sleep schedule. And I mean every day, even on weekends. Avoid hitting snooze and try to avoid binging those new episodes late into the night. Consistency is key. 2. Your circadian clock is already calibrated to the light, so exposure to bright light can help you alter your body's schedule. 3. Sleep aids and supplements, if you time them correctly, can help induce your sleep. But it's important that you only use them for a short time, long enough to teach your body your new, desired sleep schedule. 4. Circadian rhythms not only dictate when we wake, but when we feel hungry. Changing your meal times can reset your body's schedule, so can changing your meal choices. Avoid foods with caffeine, sugar, and high-fat content right before bed. Finally, if you're not falling asleep when you want, try to add exercise to your daily routine to get a cortisol boost during your waking hours. And if you're someone who likes to exercise at night, just make sure you do it 1 to 2 hours before bedtime. It's easy to knock your circadian rhythm out of sync. But the good news is that resetting your circadian rhythm can be done. It just takes a little time and discipline. Your body is very busy. It has a lot to get done in a day, just like you. So find a strategy that works best for your needs, and you'll find your circadian rhythm synchronized to your life in no time. Thanks for watching, everyone. Sleep well.
Okay, so we're going to go a little bit deeper into the sleep cycles. For NCLEX and board of nursing, there really aren't going to be questions like what sleep cycle, what stage of sleep is a patient in. We're not looking at that, but this will help you understand the overall pathophysiology of sleep and why it really is important, and then just to know that we obviously are in different stages of sleep when we are sleeping. So I'm not going to spend a whole lot of time on this. I'm just kind of briefly introducing this to you guys if you haven't gotten part of this material from an A&P class, but we'll dive a little bit deeper into more like the interventions and things like that here in just a second. So with stage 1, this is what we call that non-REM 1 sleep. This is our very light sleep, lasts only a few minutes. This is when our muscles start to relax. We start losing that awareness of our surroundings, and our vital signs and metabolism begin to decrease. But at this stage, we can still easily wake up. Stage 2, this is our REM2. It is a little bit deeper stage. This is roughly 10 to 20 minutes into our sleep cycle. Our vital signs and metabolism begin to slow as well, and then requires slightly more stimulation to wake us up. And then this further increases our relaxation. Then there's stage 3. This is a slow wave sleep, or what we call delta sleep. This is when our vital signs continue to decrease. It is more difficult to wake you up at this point. Psychological rest and restoration take effect during this phase, as well as reduced sympathetic activity. And then this will lead into what we call REM sleep, which is that rapid eye movement sleep in stage 4. This is where you can actually have vivid dreams. This begins roughly in a healthy individual 90 minutes after falling asleep, and you can continuously go in and out of that REM sleep, kind of cycling through some different those other stages, roughly every 90 minutes. As you build those healthier sleep habits, the longer this cycle will continue for individuals. The average length is roughly about 20 minutes. And during that phase, it can be very difficult to wake a patient. But this phase does help us, or this stage, sorry, does help restore our cognitive abilities. Okay, so diving a little bit deeper into the nursing process here, we're going to talk about those exemplars now. So what happens obviously when we are not getting adequate sleep? So these clinical manifestations, remember those are the signs and symptoms. This is in module 3. This is page 227. And I guess I did not write the table number down. I'm wondering if it doesn't have a table number. This book is new for me too, so I'm kind of getting used to how they've printed some of this material. 227. Sorry, guys. Let me get to that real fast. Okay, so there is no table number. It is just that giant table that says clinical manifestations. So remember, we are mostly just focusing on that insomnia and sleep apnea as you are kind of reviewing that chapter. So we're going to look first at insomnia here. So insomnia is the most common sleep disorder. It can be the process of difficulty falling asleep, or for some individuals, it can be the process of staying asleep. Can be primary or secondary. Can be either acute or chronic. Can often lead to daytime drowsiness, irritability, and fatigue, as well as for some individuals that have severe insomnia, can cause cognitive changes, deficits, and can lead to accidents. So, as I was saying, insomnia is a common sleep disorder that can cause trouble falling asleep, staying asleep, or getting good quality sleep. Insomnia interferes with daily activities and can cause a person to feel unrested or sleepy during the day. Short-term insomnia may be caused by stress or changes in one's schedule or environment. It can last for a few days or weeks. Chronic insomnia occurs 3 or more nights in a week, lasts more than 3 months, and cannot be fully explained by another health problem or medication. Chronic insomnia raises the risk of high blood pressure, coronary artery disease, diabetes, and cancer. Thinking of insomnia, I did have some family members that got what I like to call the original COVID when it first came out, back of March 2020. And I remember they're my siblings. They don't live in Texas, but I remember them commenting on the insomnia was one of these huge symptoms they had with that COVID, with their COVID that they ended up getting. So it's just something to kind of keep in mind. But as their body did better recovering from that COVID, they were able to restore their sleep. Now looking at sleep apnea, this does include periods of complete or partial airway obstruction. This is what we call inspiratory pauses that can last 10 to 20 seconds. Some individuals, it can be more, if you are diagnosed with sleep apnea, you have more than 5 apneic episodes, which basically means you stop breathing for those 5 episodes. And it basically is like, there's little short stints, like 10 to 20 seconds, but you can have, so when we're diagnosing somebody with sleep apnea, we've identified that they've had at least 5 of those apneic spells. Or for severe cases, sometimes those patients have over 30 those apneic spells in an hour. So our greatest risk with that sleep apnea is decrease in oxygenation. And then obviously it can cause non-restorative sleep, as well as daytime drowsiness. So sleep apnea is a common sleep condition that occurs when the upper airway becomes repeatedly blocked during sleep, reducing or completely stopping the airflow. If the brain does not send the signal needed to breathe, the condition may be called central sleep apnea. Sleep apnea can be caused by a person's physical structures or other medical conditions. Risk factors including obesity, large tonsils, thyroid disorders, neuromuscular disorders, heart, kidney failure, genetic disorders, and premature birth, that's any birth before 37 weeks, can lead to sleep apnea. Okay, looking into some diagnostic testing. So this is for both sleep disorders here. So is kind of a combo slide here. But when we're thinking about diagnostic testing, when we're trying to figure out what sleep disorder an individual has, oftentimes we will ask a patient to keep what's called a sleep journal, or we call it sleep diary. We'll often want to know what they're doing that day, right up until they slept, like when they went to bed, when they woke up. How many times they woke up in the middle of the night? Did anything else happen to them during the night? Like were they in pain? So we are asking them to kind of keep a pretty detailed description of their evenings and kind of how their sleep habits are going. There is something called a PSG, or polysomnography. That's a sleep study, as well as an EEG, which can monitor the video audio equipment that helps monitor an individual's um, sleep cycle. That often is done in what we call sleep centers that we arrange for an overnight stay for a patient, so that way we can actually hook them up to a machine. Here in just a second, I'll show you a picture of a patient that's hooked up, so that way we can really kind of see those sleep waves, and as well as video of the patient. So if like they're a sleepwalker, we can maybe catch an incident where they're getting up out of bed and sleepwalking. Other monitors that we sometimes often put on these individuals is a heart rate monitor, breathing monitor, O2 saturation. Especially if we're concerned about that sleep apnea side of it, we want to know how low their oxygen's dropping, or some patients that have maybe dysrhythmia or bradycardia, is that heart rate dropping down to like 30 or 40? Do we maybe need to consider a pacemaker to kind of help keep that heart rate up? Maybe that's why they're having trouble with sleeping. Those type of effects there. So that's some of our diagnostic tests. And so this next picture, I was trying to remember which slide it was on. It's this one here. Okay. So this is a patient that we've set up at a sleep center. That obviously you can see he's got lots of little wires all over him. So this patient, a sleep study may be ordered for patients that we suspect of having a sleep disorder. A sleep study monitors and records data during a patient's full night's sleep. A sleep study may be performed at a sleep center or at home with portable diagnostic devices. They have come a long, long way with those diagnostic devices. I remember my stepdad actually has sleep apnea, and I remember when he first got diagnosed, this was, gosh, back in the 90s. And so he had to like go stay the night somewhere. And now a lot of the equipment that we can use with the patients, they can actually go home with the monitor, where it is more natural for them to be in their own bed with their possible spouse, or if they like to sleep with a pet. Like you don't have to, it doesn't have to be such a foreign environment. You can actually, they have portable equipment now that can be set up at the bedside, and we can hook up the patient similar contraption like this individual is wearing, and then they can actually see what's going on while they're trying to sleep. Obviously, this does describe, if done at a sleep center, the patient will sleep in a bed at the sleep center for the duration of that study. Obviously, these sensors are removable, and as you can see from that picture, they are on his scalp, face, eyelids, chest, limbs, fingers even, just to record those brain waves, and that kind of helps the doctors know how deep or which stage of sleep those patients are in. Is he only staying in that non-REM 1 and 2? Is he ever get to REM 3 or non-REM 3? Is he ever getting a REM cycle? Yeah, so that's why it's important to kind of know those stages. There is a small risk of some irritation from sensors. I don't know if anyone's ever had like even EKG stickers, things like that. Some patients do seem to be more susceptible or have trouble with adhesives. Just kind of keep that in mind as you work out in practice someday, that some patients may not tolerate certain sensors. But they've come a long way with those as well. Now we even have latex-free things. Anyway, getting off course here. But just wanted to let you guys kind of see what that looks like on an individual. And then they obviously go to bed and then let the monitor kind of record everything for them. Okay, so let's break down insomnia just a little bit here. So what exactly is insomnia? So insomnia is lying awake for a long period of time before falling asleep, or like I was talking about before, it's also the inability to go back to sleep. So if you keep waking up and then not being able to go back to sleep, some patients just have they can have a combination of it. So they can have just the insomnia where they're having trouble going to sleep, or they can have that combined where they have trouble going to sleep and they have trouble staying asleep as well. Um, the ability to fall asleep, those that have that insomnia type, that is more common, obviously, with our younger adults, teenagers, even. I question whether and you guys are most of you guys are young too. If anything, if that has anything to relate to the use of our smart devices, cell phones, things like that, if that's interfering with some of that insomnia, if we're just getting so much stimulation right before bed. Just one theory. I think the book talks a little bit on some healthy habits, which I'll talk about again here in just a second, kind of establishing um, those patterns. With insomnia, this does involve sleeping for only short periods of time because some of these individuals often do wake up multiple times during the night. This is the most common symptom and typically affects our older adult population. It can involve waking up too early in the morning and then not being able to get back to sleep, as well as having poor quality sleep. So, for those individuals, we're talking about those that never really get into that REM cycle. They're really never getting that true, or even that stage three. They're not getting that restorative, really good sleep. So, these patients often feel very sleepy during the day. They can often have difficulty focusing on tasks. Insomnia can also cause irritability, anxiousness, and depression. I don't know why, but right now I'm thinking of like newborn parents that have a newborn baby. I always think of those poor individuals because those first few weeks of a newborn's life, that waking up sometimes hourly to every 2 hours to feed a baby, it can really cause some difficulties. Very groggy, very sleepy, trouble focusing, staying on task. So definitely, I don't know if all of you guys have kiddos, but it's just something when I think of insomnia and I think of some of the roughest times I've ever had sleep in my life, I kind of think of those newborn stages with my kiddos. Some insomnia is more common in females, especially over the age of 60, or individuals that have some mental health disorders as well. I also think of, I hate to keep giving examples of my family members, but it's the best thing I can think of right this second. But I think of my youngest. She does have ADHD, and sometimes, especially during the week when we've given her ADHD medication, there are some evenings that she does have a little bit of trouble winding down. So we do support her with our physician's guidance, giving her a little bit of melatonin at bedtime. We call it her nighttime vitamin. And that does really kind of help suppress that stimulant that she's had during the day to get her through her school. Other secondary factors can be cause of insomnia, to include depression, anxiety, obviously life stressors, chronic discomfort, restless leg syndrome, and then environmental conditions. Environmental conditions, I always think of maybe this time of year when the air conditioners break and it does get stuffy, or maybe if their room is too cold. Any of those little factors that would keep a person from really getting some good deep sleep. Okay, so what are some nursing interventions? These are included on page 229 through 230. And again, I'm not going to dive deep into this pharmacology side of the medications that you are learning about these meds in pharm. So I'm not going to, I'm only just going to touch on them, and I'm going to point you to those tables to make sure you memorize these meds. And again, you need to know these medications, you need to know their side effects, their half-life, as well as pertinent patient education. Like, should the first time they ever try some of these medications, should they be trying them alone? Probably not. They should at least maybe have somebody with them so that that way they can monitor for some side effects. I'm thinking of like Ambien right now. Some patients do have like sleepwalking sometimes with these medications, things like that. So it's little things like that that it is good to obviously involve other family members or support systems before just starting pain or no, I'm sorry, sleeping medications all the time. Obviously, there are different types of pain. So sorry. There are different types of sleep medications. There's the sedative hypnotics, the anti-anxiety medication, barbiturates, benzos. Just really make sure you do understand those half-lives and the effects of each one of those medications. Some other meds I want to mention that your book does briefly talk about, especially now in our day and age. If we were living, I was in Colorado and New Mexico, would be a lot more prevalent. But CBT is becoming very popular with a lot of our psychiatrists now. Um, Psychologists, I mean, it is actually one of the first line of medications. I guess you're going to call it a medication. Treatments for insomnia. A lot of psychologists are now prescribing marijuana or CBT. Let me rephrase that. CBT, not marijuana, to assist patients with insomnia. Um, some other things that don't involve those stronger sleep aids do include some relaxation techniques, sleep restriction. I think of like sleep restriction as in just not taking naps during the day. So if you have somebody that's not sleeping great at night, that's when you're trying to say, okay, if you're not sleeping but more than 3 hours at night, maybe we should stop taking the naps throughout the day, and then let's see how long you can sleep in the evenings, that type of thing. Some other non-pharmacological approaches do include some cognitive behavioral therapy. So that's more like if we're dealing with like depression or anxiety that could be causing that insomnia, making sure that we're dealing with some of those emotional stressors, developing just like those good sleep hygiene, like turning off the electronics a couple hours before bed, physical exercise, not right up until the moment you go to bed, but maybe a few hours before you go to bed, you can do some physical activity. Even some of those nasal strips or getting those sleep studies to see, or do you have that sleep apnea that could be also contributing to your difficulties. Okay, sorry, there we go. Diving back into our sleep apnea now. So sleep apnea is reduced or absent breathing, known as apneic spells or events. Common characteristics or manifestations that the book likes to call them do include frequent loud snoring, gasping for air during sleep, excessive daytime sleepiness and fatigue, decrease in attention, vigilance, concentration, motor skills, and verbal and visio spatial memory, dry mouth, headache when walking, or headache when waking, sexual dysfunction, decreased libido, waking up often during the night to urinate. So sleep apnea is diagnosed by a healthcare provider based on a person's medical history, physical exam, and results of a sleep study. During sleep studies, the number of episodes of slowed or stopped breathing, that's those apneic spells, are recorded along with the documentation of their oxygen levels in their blood system during those events. So they can actually see when that person has that apneic spell for that 10 to 20 seconds, they can actually see that their O2 will drop from, like, let's just say they start at 98, it can drop, 89. I know on my stepdad that has the sleep apnea, he had a few of those spells that lasted, I think it was over 40 seconds, and his O2 dropped all the way down to like 88 at one point. So yeah, he has a CPAP machine, but we'll go over that in just a second. So there are 3 types of sleep apnea. They do include obstructive, central, and mixed. So obstructive sleep apnea does include that is when our airway is blocked. This can actually be from something called that it can actually be caused from our soft palate, tongue, or uvula. And oftentimes, if it's obstructive, they can also have that snoring as well. I don't know if any of you guys have ever had kiddos with had to get tonsils and adenoids out. Um, Sometimes because of the reoccurrent like tonsillitis and strep throat, as well as the way that their adenoids have grown, it can cause like that inflammation in that back of that throat that can cause obviously that obstructive sleep apnea. And so sometimes those physicians, when they're taking tonsils out for those patients, especially I'm thinking of kiddos, kiddos are known for snoring, sometimes the doctors will go ahead and remove those adenoids to see and help to see if that is going to relieve that snoring habit that's happening. Central sleep apnea does include the muscles in the chest and diaphragm. This is when our central nervous system fails to communicate to our respiratory center of the brain to trigger the patient to breathe. One example of this I can give you guys is a patient that I had to do CPR on. I was working for a clinic. It was probably very similar to like the family physician clinic here in Amarillo, but it was like 10 times bigger. I happened to be walking. They even had like 5 different levels to this clinic. And then on the first floor was your x-ray and pharmacy. And I happened to be going to the pharmacy to get something for a patient. And when I was walking past the pharmacy, I walked past the CT scan room, and the radiology tech that was in there screamed for help. And I walked in there, and this patient had central apnea while he was getting his CT scan, and actually had stopped breathing because of obviously that signal to his diaphragm to take a breath. And we were doing CPR on this individual. Unfortunately, there was obviously a time frame between when the tech recognized that the patient had stopped breathing, and the time lapse between when the CT scan started and when it ended. So unfortunately, by the time we got there, started the code on this patient, it had already been well past like that 2 or 3 minute mark. And unfortunately, this patient did pass away. We were able to get his heart back. I think it was about at least one time, but pretty much by the time the ambulance got there, he was gone, and he passed away from hypoxia. And unfortunately, that's the reason why he was down there for that CT scan, was to identify if he was having something physically going wrong with that diaphragm, but it ended up being some central sleep apnea that he had undiagnosed, and he quit breathing. So sleep apnea is something that can be very, very serious, and it really has to be taken very seriously. If you ever have a patient that's newly admitted to the hospital and tells you he has sleep apnea, you need to get on the phone to your central supply team, respiratory therapy, to get the CPAP machines, whatever they need, so they can continue wearing whatever they need, so you don't have that type of incident occur for you guys. It was probably one of the worst codes I've ever been in, to be honest. It was one of my first codes outside of the hospital setting. It wasn't a clinic per se, but this clinic was pretty advanced compared to like what I think of like, I don't know, like an urgent care or something. We had all sorts of specialties in one giant building. So we saw a lot of things, and that was probably one of and we coded patients, I would say, because all sorts of patients would just walk in sometimes to that office. But it was probably one of the worst codes I've ever been involved in. It was really rough. Anyway, just want to really make sure you guys understand that sleep apnea is very serious. Our primary, forgot the other type of sleep apnea. The other type is called mixed, and it can have characteristics of both. So they can have that obstructive sleep apnea as well as that central sleep apnea as well. So our number one risk factor for sleep apnea is obesity. Other factors do include a large neck circumference, narrow airway, smoking, and some genetic links. So if you have like maybe a family history, sometimes there is a genetic link. Those are seen more in Hispanic, Black, and Pacific Islander population groups as well. Okay, so sleep apnea interventions. So this can be found on page 230. There is an education box I want to make sure that you guys do look at. I've highlighted it here for you. And then do look at that picture of that CPAP with that patient on that picture on page. Oh, shoot, I didn't leave that for you. Sorry. It is figure 3.12. It is on page 230. That's probably why. Okay. So that gentleman is wearing a CPAP device there. If you aren't familiar with CPAP machines, there are so many different types now that they have, especially different facial masks. I know for my stepdad, he never liked the mask one. He actually has one that goes more in his sinuses, and it just is a continuous amount of pressure that just keeps that airway and our diaphragm from completely collapsing. So that way we have that continuous pressure. Doctors during that sleep study will play with different parameters to get that right concentration of pressured air to find what works great for that patient. Is this something easy for patients to use right away? No, because unfortunately, if they've lived their entire life with possibly sleep apnea or that developed into their adulthood, it can be a hard transition from going in from using a CPAP machine, but it's really, really important that patient education. We need to make sure that they are using the device accurately, that the mask is properly fitting them, whatever mask that they are choosing, and that they're not, that settings maybe don't need to be adjusted to provide that exact comfort that a patient needs. When patients do not tolerate CPAP machines, they can surgically sometimes go in there and fix that obstruction, especially if it's something like that uvula that I was talking about, or like when I was talking about the adenoids or tonsils. We can sometimes remove those items, not the uvula, but we can maybe reduce the size of the uvula, but we can obviously remove adenoids and tonsils if needed to kind of help open up that airway as well. Some other suggestions just to improve our risk for sleep apnea do include weight loss, alcohol abstinence, avoiding supine position for sleeping. So I don't know if you guys learned the word supine in your medical terminology, but I always think of the word soup. And how do we eat a bowl of soup? We eat it facing up, obviously. So that's how I always think of a person. So those that just really be careful when we're positioning these patients. We don't want them completely flat, just like that guy that passed away on the CT machine. For that gentleman, it would have been, if we would have known he had what he had, obviously we would have hopefully had an O2 monitor on him and been watching his breathing the whole time he was flat. Something else that they may use in addition to a CPAP machine is called a BiPAP machine. And that can also provide kind of intermittent pressures to kind of keep that airway open for patients, especially when they're sleeping. Okay, so a couple last things here to wrap up this lecture. I'm going to talk about just some of the recommendations for the amount of sleep. So the book briefly does break down the different age groups and kind of what to expect for sleep. I'm not expecting you guys to memorize these, but just know roughly that obviously our infants up to 1 year, they're needing the most sleep out of all of us, right? And then older adults, and then obviously 18 years and older, we are needing less sleep as we get even older. So it even talks about our geriatric population, sometimes they only get 5 to 6 hours of sleep, and that's what's recommended. Obviously, our kiddos, because we're growing so much, and then even including in naps, as you can see, they get quite a lot of sleep. And and then it obviously decreases as we age. So some other things to kind of keep in mind about sleep is what happens when we don't get enough sleep. This is called sleep deprivation. This occurs when a client does not meet the body's biological sleep requirements. Sleep deprivation can affect higher order cognitive functions, impair judgment, decrease response time, and trigger seizure disorders, migraines, or attention headaches. Now, I'm not saying that I don't want you to take that to heart, as in completely black and white, that if you don't get enough sleep, you may have a seizure. It's just something that the book mentions. Does every person that doesn't get an adequate sleep, do they have seizures? No. But maybe if they are prone to having seizures or have a condition like epilepsy, maybe the inadequate sleep can maybe trigger those seizures. So just kind of keep that in mind, okay? Especially with migraines. I think of a friend of mine that gets migraines at any time that she doesn't get a full night's rest. It is pretty consistent. Like that for her is the trigger for her migraine, is the amount of sleep she gets each night. So the important thing is to promote healthy habits. This can be found in boxes 3.1 and 3.2. These are the guidelines for sleep hygiene and minimizing stimulation in the hospital. So some of these do talk about avoiding caffeine, alcohol, nicotine 6 hours before bed, removing unnecessary light, using blackout curtains, establishing a bedtime routine. I always think about kiddos, like giving them a warm bath, bedtime story, things like that to kind of get them wind down. Go to bed when tired. If not able to sleep within 20 minutes, try another room or get up and read for a little bit, turn away from the clock, go to bed and wake up at the same time each day, keep naps short and before 3 o'clock if we're talking about children, and complete exercise at least 3 hours before going to bed. Remove work items, televisions from the bedroom when possible. The bedroom should be a place for sleep. Okay. So that is it for this lecture today. I will try to keep doing these vid grids. There may be some weeks that, depending on my schedule and the content, that it may be easier to do the lecture part in class. But as much as possible, I will try to include these longer deep dive lectures with the PowerPoint slides more like a vid grid for you guys to watch at home. That way you can kind of pause, rewind, watch them when you can. But I definitely advise you to watch them before we go through the material in class. That way you are better prepared for the activities and possible quizzes that we will take in the classroom. So make sure you do read through Module 3. The book likes to call everything modules instead of chapters. So if I accidentally say chapter, I mean module. So Module 3, sections 3.A and 3.A and 3.E, as well as Module 7.C. Those are those exemplars that we did cover today. I do look forward to meeting you in class this week, and I'll see you very soon. Thanks.